Okay. Welcome to PowerPoint number 2, where we're going to really get into, delve into our EKG interpretation. We'll start talking about our lead system, what we have on our EKG monitor. I'm not really sure, if you guys, how familiar anybody is with this information. So we're really just going to start from the beginning and cover most of it in fairly good detail. So whenever we hook our patient up to the electrical or the EKG monitor, generally using a 3 or 4 lead system, we're hooking up. What we're doing is putting an electrode on the right arm, the left leg, and then the right leg. And this is just our 4 lead monitoring. What we're doing with this, whenever we hook this patient up to the 4 lead monitor, is obtaining a 3 lead or a 3 lead EKG. What this means is we have a set of bipolar limb leads, which these are referred to because they go on the limbs. We have leads 1, 2, and 3. And if you look at this picture here, you can tell what lead is what by looking at the graphic representation. What this makes up whenever we have our 4 leads on, we're just actually going to be referring to it as a 3 lead, since the right leg, we're just going to leave it out for now, and we'll just get in more detail later. So we have leads 1, 2, and 3. And looking at lead 1 here, if you remember from the last PowerPoint, we discussed the fact that each lead has a positive and negative electrode. The positive electrode in lead 1 is our left arm. The negative electrode in lead 1 is our right arm. The positive electrode in lead 2 is our left leg, and the negative electrode is our right arm. And then in lead 3, the positive electrode is our left leg, and the negative electrode is our left arm. So from that, we can tell what these leads are really going to be looking at. So remember we talked about there was each lead can be looked at as a camera, and the cameras are looking from different angles. So if we had our camera, we'd put that camera at the positive electrode, and that's really what the direction that the camera is going to be looking at. So we are able to say that lead 2 and 3 are really looking up from the bottom. You see, these are our positive electrodes. The left leg is our positive electrode. So our camera is right here on lead 2, looking from the bottom left up to the right arm. And then our camera on lead 3 is down here looking up at the left arm. Both these leads are looking from the inferior side part up. So what would we expect? Remember that we talked about a deflection is going to be positive on the EKG if electricity is moving towards it. Well, in the normal person, our electricity is moving from the right arm down towards the left leg. And we're looking from the left leg up. So that means electricity is moving towards that left leg. So our wave should be positive in those leads. And we'll get into that in greater detail when we start talking about the axis of the heart. The camera for lead 1 is located over here on the left arm, and the negative electrode over here on the right arm. So our camera is looking from the left side of the heart over to the right side of the heart. So in general, electricity is also moving towards the camera on lead 1. So we would expect that to be positive as well in our ECG tracing. You also have, whenever you hook up your 3 lead EKG, what are called augmented leads. As opposed to the bipolar leads, the augmented leads are unipolar. What this means is they only use one electrode as the positive electrode, and then the negative, it's not an electrode, but what our negative is going to be our what's called Wilson Central Terminal, which is just a arbitrary location that's located at the center of the electrical conduction system in the heart. So what we have augmented voltage right, augmented voltage left, and augmented voltage foot. So augmented voltage right is looking from the right arm to Wilson central terminal. So the positive electrode is the right arm, the negative is at the center of the heart. Augmented voltage left, the positive electrode is the left arm, and the negative electrode is at Wilson central terminal. And then augmented voltage foot, the positive electrode is the left leg, and the negative electrode is Wilson central terminal. From that, we should be able to tell if these waves should be positive or negative based on the positive electrode. So for example, augmented voltage right. This is our positive electrode, and this is Wilson central terminal. So the camera is right here, and it's looking this way. So we said that electricity is moving from the top right down to the bottom left. So is electricity moving away from or towards this camera? That's right, it's moving away from. Therefore, in 99% of patients, whenever we look at AVR is going to have a negative deflection on the EKG. Very rarely will you see a positive deflection of AVR in our EKG, and most of the time this is secondary to the limb leads being placed incorrectly. Something we'll talk about in more detail later is our precordial leads, or V1 through V6. These are applied anytime we're doing a 12-lead EKG. We'll talk about placement of these later on. Just remember that they are unipolar leads that are placed on the chest and give us a more detailed picture of what's going on in the heart. And we'll talk about those later. Everything that we discuss now is going to be based on our 3-lead EKG. This is an example of the hexaaxial system for our limb leads. We'll talk about axis in greater detail later. Just know that we have 4 quadrants that are based on the electrical stimulus of the heart and what direction the electricity is traveling. So whenever we start talking about axis, just kind of keep this in mind that we're going to use this hexaaxial system to determine the mean flow of electricity in the patient based on their EKG. As we already discussed, here's our positive and negative electrodes for each lead. All right, we'll talk about the EKG paper. So whenever you get a piece of EKG paper, if you guys have never really seen it, most of you guys are already familiar with this. But this is what it looks like. It's got tiny boxes and big boxes. Each small box is representative of 0.04 seconds moving sideways, or 0.1 millivolts in moving vertically. A big box is 5 of the small boxes, so it's equal to 0.2 seconds, or 0.5 millivolts. Once again, here's our example. This is one big box. Inside are 5 by 5 of the small boxes. 0.2 seconds in total, or 0.04 seconds in each small box. If you look at your EKG paper, most of our cardiac monitors, whenever it prints out, will have small ticks on the bottom of the paper. In between each of these ticks is representative of 3 seconds. So you have 3 seconds from here to here. This is 6 seconds, 9 seconds, 12 seconds. At the beginning, I believe I have a picture of it later on. If not, we'll look at some. Anytime that you do an EKG, at the very beginning when you start printing out your strip, you'll see 2 small rectangular box on each lead. And what this is a calibration box. This should be printed on every EKG that you print off. If it's not printed on there, then you really can't trust your EKG. Because what that machine is doing is calibrating to the boxes to make sure that it's printing correctly. Okay, so here's a good picture of the relationship of the EKG to the electrical events going on in the heart. We're going to talk individually about each of the waves that occur, the segments that occur, and get into details on those. But just as a generalized picture here of what we're looking at. So you guys remember from the last lecture, we talked about our electrical stimulus traveling down from the SA node all the way down to the Purkinje fibers. Right here we have depolarization of the SA node. Our atria are the first chambers that are going to be depolarized. So they're being depolarized by the time the stimulus reaches the AV junction. Once they kind of all pass through the atria, we'll start seeing our P wave. What the P wave is representative of is our atria being depolarized. Right here, remember we had a pause because we want time for those atria to depolarize before the stimulus reaches the ventricles. That's while that stimulus is traveling through the AV node and the bundle of His. Once the stimulus passes through the bundle of His, it very rapidly reaches down to the bundle branches and the Purkinje fibers, and we have a QRS complex, which is indicative of our ventricular depolarization. Remember that the ventricular depolarization is not indicative of ventricular contraction, rather just the electrical depolarization of the ventricles. After this, remember on the on our action potential slide with that, we saw that as potassium's being pumped out of the cells, the ventricles are repolarizing to become ready for the next stimulus. They have to repolarize and get back to their previous state before they can receive another stimulus to pump again. So that's what's occurring here at this phase. Atrial repolarization is not normally seen on an EKG. It occasionally can be seen, but most of the time it's hidden by the QRS complex. You'll also see I have noted on here the U wave. Sorry about that. I just changed the slides and I can't go back. You did see what was called the U wave. Occasionally you'll see this on some patients. It's not generally seen. It's very rarely seen, to be honest. Most of the time it's secondary to some type of electrolyte derangement, and the cause of the U wave is actually unknown. They really don't know what it is representing. It could be delayed repolarization of the ventricles, or just a mirror effect of the ventricular walls. Nobody really knows what the U wave is, and what it usually looks like is just a small wave, smaller than the T wave, seen in the same direction as the T wave. All right, so we'll get into talking about some of these waves here in more detail. So we have our impulse that's initiated in the side, and this is before. All right, we have our baseline here. And for the purpose of this conversation, we're talking about lead 2. Lead 2 is the most common monitoring lead because if you remember, the direction of this impulse down and to the right, our positive electrode is the left leg and our negative electrode is the right arm. So it's kind of in line with the direction of this general or average electrical direction or flow. So it's a very good monitoring lead because it shows us the best overall picture, and it kind of gives us the general look of things whenever we're monitoring a patient. So the P wave should always be upright in lead 2, and what happens as our impulse is Okay, so as the stimulus is passed down through the atria, and the atria depolarize, this is where we're going to see the beginning of our P wave, which is the beginning of atrial excitation. By the time P wave is complete, we'll have completion of atrial excitation as that stimulus spreads down through the atria. And then we'll get to the point where the atria begin to depolarize. All right, after the atria depolarize here, we have a small pause, as we already discussed. This pause is called the PR interval. This is the delay of the impulse at the AV junction. This is where we're going to have the stimulus meeting up at the AV junction and our pause for the atria to continue or finish their contraction before the impulse is generated down into the ventricles. So this is what the PR interval is. The PR interval is the
Medic 55 is en route, 1308 West Cypress.
Is the
I have a 71-year-old female who's advising that she is having difficulty breathing. The pain in her right shoulder is now radiating up to her ear on the same side.
So the PR interval is the distance from the beginning of our P wave all the way to where the QRS segment starts, and we'll look at that in the next segment here. We have our QRS complex here, and this is representing the depolarization of the ventricles. This happens very quickly. After our QRS complex, we have a T wave. The T wave is indicative of ventricular repolarization. So our ventricles are getting back to their normal state. Here we have all the components of the EKG, or of the each wave on the EKG. Beginning with the P wave, we have the P wave. We have the PR interval. Okay. Now, you'll hear reference to the PR interval. You can also hear the PR segment, the ST segment. What the difference is, the PR interval is including the P wave all the way up to the QRS complex. The PR segment is just the distance after the P wave to the beginning of the to the QRS complex. So it's just this small segment without a wave in it. A segment does not include a wave, whereas a interval includes a wave. So we have our PR interval. The normal interval lasts a duration of 0.12 to 0.2 seconds. So it should be less than one big box. And remember, 0.4 seconds in each of these small boxes, 0.2 seconds in a big box. So the duration of the PR interval should be less than one big box. The QRS interval is 0.08 or 2 small boxes up to 0.12 or 3 small boxes. Anything greater than 3 small boxes is abnormal. Our ST segment is right here. Important to remember that our ST segment should be at the isoelectric line, which is right here. Our isoelectric line and should not be elevated or depressed. Our T wave is here. The the T wave, the QT interval is the distance from the beginning of the Q wave to the middle of the T wave here. So, or the end of the T wave, I'm sorry. And that distance should be less than 0.42 seconds. You can hear that kind of manipulated. Sometimes you hear up to 0.45 or 450 milliseconds. It depends on what you're looking at. And you can run into some problems with whenever you have that QT segment getting longer. We'll talk about what happens when that QT segment elongates later on in the lecture. Just another picture of our basic segments. The TP segment is from the end of the T wave to the beginning of the next beat. So at the beginning of the P wave, we have our P wave. We have our PR segment here. We have our PR interval from the beginning of the P wave to the beginning of the QRS. We have our QRS complex, our ST segment, our T wave, and we have our QT interval from the beginning of the QRS to the end of the T wave. The baseline or isoelectric line is an imaginary line drawn from TP segment to TP segment. So it should always be flat. And here, you know, between our beats, it should be flat. And then
I'm sitting here in a vehicle over on 12th Street.
and you can kind of run that imaginary line through the complexes, and that's help us determine some things later on. Talking about the P wave, the first wave in the complex, like we said, it represents atrial depolarization. The normal P wave is 0.08 to 0.11 seconds. You can have some different looking P waves, morphology, whenever you have ectopic foci that are causing the P wave. Like we said, if you guys remember, the P wave or the pacemaker cell isn't always going to be the sinus node. That pacemaker cell or that beat can sometimes originate from somewhere other than the sinus node, and that's going to make obviously our P wave is going to look different if it's not the same clump of cells that's providing that stimulus. So our example here, you have the sinus node originating, and this is our normal looking P wave here. If we have an ectopic or unusual atrial focus that's causing the stimulus, obviously our P wave is going to look different. In this example, I mean, it can look like anything. You can have it inverted. You can have it sitting real close to the QRS complex or further away. And this could be a single beat or it could be multiple beats. You could have them, that could just be what their rhythm looks like. Or they could have every once in a while ectopic focus given a beat that makes it look different. Here we have an example of a junctional focus causing the beat. Sometimes you'll see the P wave still if the junctional focus provides the stimulus because it retrograde depolarizes the atria, so they depolarize backwards, and that could be represented by a negative deflection on the EKG that's really close to the QRS complex. Here we have two examples of our ventricular foci causing a stimulus. Most of the time, you're not really going to see a P wave if you have a ventricular focus that's causing the beat. Occasionally, you can see it retrograde conducted backwards through the electrical system, but it's not very common. The TP wave represents atrial repolarization. You're not going to see it because it's buried by the QRS complex. So it's kind of occurring at the same time. Remember that we see the ventricular repolarization. So obviously the atria also have to repolarize. They have to get back to that normal state. But you're not going to see it because most of the time it's buried under the QRS complex. Our PR segment is from the end of the P wave to the beginning of the QRS complex. It may be depressed by less than 0.8 millimeters or milliseconds in normal circumstances. And this should be on the isoelectric line. Our PR segment should always be on the same level as our isoelectric line. The PR interval is from the beginning of the P wave to the beginning of the QRS complex. The total duration should be 0.12 to 0.2 seconds. Here we have an example of what we're looking at as our, in reference to our depolarization of the conduction system. So we have our SA node fire right here. Our atria are depolarizing right here. Here we have the stimulus slowing down in that AV node and through the His bundle. It reaches the bundle branches, and then once the Purkinje fibers fire, that's when we finally get our QRS complex. The QRS complex represents ventricular depolarization. It's typically composed of two or more waves because we do have two bundle branches or two sides. Both ventricles are depolarizing, so we see different deflecting waves here. Normal duration, you can see it anywhere from 0.06 to 0.11 seconds. Normally, anything longer than 0.12 is considered abnormal. Not always going to have a QRS complex specifically. Actually, the QRS complex is kind of a misnomer because generally.
Fire response to 711 South P. Boy for possible gas leak.
Okay, sorry about that, guys. Picking up where we left off, we're talking about the QRS complexes. I mentioned in the last slide. The QRS complex is kind of a misnomer. Most complexes, the QRS complexes that you see on your standard EKG in a healthy patient, they don't typically have a QRS complex. The reason for that is, and we'll get into this in more detail on this next slide, and it'll kind of explain why just a little better. You don't have the each of those waves as the name QRS complex suggests. So if you look here, note that you do have some different complexes that are considered. I mean, these can be normal as well. So if you look at and it'll make more sense as we talk about each wave specifically. These are, so this first one here would be considered a R prime complex. Both of these waves are up above the isoelectric line. This would be also a R prime complex as well as this one. This is a RSR prime complex down here on the left, and then a RSR S prime complex here. And basically, each, if you look at these, the representation of the name, the wave that's smaller has the small lowercase letter, and the larger wave has the uppercase letter. In the instance of, we'll talk about these two down on the bottom a little later. Hopefully this will make sense after. Okay, so hopefully now that we're going to get into some of the specific waves in these complexes, this will make a little more sense what I'm talking about. So we're going to talk about the Q wave here. You won't always have a Q wave in every lead. You may not have any Q waves in any leads, depending on what the complex looks like. So when you do have a Q wave, what you'll see, and I'll be honest with you, I just realized that my cursor isn't showing up on whenever I'm recording this PowerPoint presentation. So you'll have to bear with me. I'll try and explain, be a little more explanatory as to what I'm talking about in relation to the what's on the screen. So if you look at the highlighted red, that's obviously going to be our Q wave, and what this means is the first downward deflection below the isoelectric line in a complex. So in this other complex, this is a QRS complex here. We do have that first downward deflection. Speaking of Q waves, I will mention, if you look at the picture on the right and you see the Q wave, it says greater than or equal to 0.03 seconds, and it says greater than or equal to 1/3 of the height of the R wave. And the reason I have this in here, whenever we get to talking about ischemia, infarctions, necrosis of muscle tissue, we'll learn that a Q wave is actually indicative of some type of old injury. So it's important to keep in mind that we can have non-pathological Q waves. We can also have pathological Q waves. A non-pathological Q wave is nothing to worry about in a patient. It's not indicative of an injury. It's there for whatever reason, and they're usually going to be idiopathic. If we do have a pathological Q wave, more than likely it's indicative of an old injury, a previous MI, or previous ischemia of some type. The way that we're able to ascertain if a pathological Q wave is pathological or not is by these factors that I have in the right side picture. A Q wave that is greater than or equal to 0.03 seconds in width, or one small box or bigger, is considered pathological. Or a Q wave that's deeper than 1/3 the height of the R wave is also considered pathological. Excuse me. So both of these Q waves that I have an example here on the right side would be considered pathological due to the width on the first one and the height on the and the depth on the second one. The intrinsicoid deflection is the first from the beginning of the QRS complex to the beginning of the downstroke of the R wave. So you see in the picture here, it represents the time of travel from the Purkinje system to the epicardium. So that Purkinje system, it has to travel through the myocardium all the way out to the surface, the outer surface of the heart, before contraction starts. And contraction starts from the inner myocardium to the outer myocardium. And this is the representation of that depolarization of that tissue. So it's usually about less than 0.035 seconds in the right precordial leads, and less than or equal to 0.045 in the left precordial leads. Not a real important value to remember. Really, the overall width of the QRS is the only value that we need to remember, what's normal and what's abnormal. The ST segment, as we've already discussed here, is the from the end of the QRS complex to the end, or to the beginning of the T wave. And just a reminder here that what we've already discussed, a interval includes a wave, whereas a segment does not include a wave. It's just the baseline. So the Q wave, or the ST segment here, does not include the wave. It's from the J point, which is the end of the QRS complex, to the T wave, the beginning of the T wave. It should be at baseline. Any abnormality from that, I won't say any abnormality. There is some variations where you won't have a ST segment at baseline, and it's still normal. But in general, for right now, our ST segment should always be at the baseline or at our isoelectric line. The ST segment changes can be associated with myocardial infarctions. We'll get into that in more detail as we talk about 12-lead EKGs. And they're associated with ischemia, injury, and necrosis, or cell death. The T wave represents ventricular repolarization. The T wave should be asymmetrical. It typically has a slow upstroke and a fast downstroke. Usually the T wave is going to be 2/3 up. The width of the T wave is going to be 2/3 of it going up, and then 1/3 of the width going down. So if you see in the picture here, you have that slow upsloping T wave, and then the faster downsloping of the end of the T wave. And it takes about 2/3 of the total width to go up, and about 1/3 to go down. You will see variations of this, and there's certain pathologies that will be able to determine what's going on due to those changes in the T waves. All right. In relation to our ECGs, we need to be considering our refractory periods. So, and what this means is, at any time, and we'll get into more detail on what these are later, but we can have premature beats that occur that for whatever reason, but they occur out of turn. So we don't have a regular heart rate. We have premature ventricular contractions. We have premature atrial contractions, premature junctional contractions. There's a lot of premature beats that can occur. So we have two refractory periods during a single heartbeat. We have the absolute refractory period and we have the relative refractory period. During the absolute refractory period, the conduction system in the heart cannot receive another electrical impulse. It's impossible for that impulse to occur because if you remember our action potential, the level of electricity in the action potential is not to the point where it's able to receive a second impulse because it has to be in that range to where it's...
We're en route Wichita, 1 code red, beginning mileage 0.0. 54 at 1802.
We're in that absolute refractory period where the conduction cells are at a point where they're unable to receive a stimulus no matter how strong that stimulus is. Then we have on the other side, on the right side, the relative refractory period. And what this is, those cells are still refractory. They're attempting to return to homeostasis and get back to that resting potential of negative 90 millivolts, but they're not back there yet. But they're close enough to it that they're able to receive another stimulus if that stimulus is strong enough. So you can have a beat occur in the highlighted red of the relative refractory period. You can have a beat occur there, and there is some problems that arise from there. So we need to be very concerned whenever we see patients that have beats that are occurring on or near the T wave, because it can precipitate sudden cardiac death in certain situations, and something that we'll talk about later on, R on T phenomenon, and what we'll get into in more detail as we move forward. The QT interval, as we already discussed, the beginning of the QRS complex to the end of the T wave should be less than 450 milliseconds or 0.45 seconds. We should be kind of cognizant of the fact that the QT segment is rate related. As rate speeds up, the QT segment can shorten, and we can also have a lengthening of the QT segment with slower heart rates. The QTC we'll talk about later on whenever we're talking about our 12 lead EKGs. Is the computer in our cardiac monitors figures a corrected QT relative to the rate that the patient, the heart rate that the patient has, using an algorithm. And this is a pretty useful tool. Whenever we start having patients that have a longer QT than normal, we need to be very concerned with the possibility of having what I was talking about in the previous slide, R on T phenomenon, and things like that we'll discuss in greater detail. As I previously mentioned, this is an example of a U wave. It's a wave that is sometimes seen. It usually occurs in the same direction or deflection as the T wave. Not seen very often. There is some drugs that can cause U waves, such as it's fairly. Sometimes you can see it in patients that are taking digoxin or lanoxin, but it's very uncommon to see. And like I discussed at an earlier time, the U wave is of unknown origin. They don't know what really causes it. Just a couple intervals to be aware of. We also have the R to R interval, which is just the difference between, or the measurement between two QRS complexes, and the P to P interval, which is the measurement between two P waves on two separate beats. Okay, so interpretation of EKGs. There's some basic criteria that we're going to discuss before we get into it. We need to be consistent and we need to be analytical. We need to memorize the rules for each dysrhythmia. by this point, I'm attempting, let's say, I have a really good cheat sheet that I'll make sure we all have access to. Keep that in front of you as we move forward. It's going to really help you out in analyzing and kind of getting familiar with each of these heart rhythms. And learning the rules for each one, and just kind of being able to compare between them. And it'll just help out a lot as we move forward to make sure you guys are able to understand. Hopefully by the end of it you won't need that cheat sheet, but it is something to keep handy for a good refresher at a later date. So we need to analyze any rhythm according to a specific format. So look at the EKG strip and try and look at it the same way you look at all of them. There's always going to be things that jump out at you, but really try and look at those and remember the rules for interpretation, and look at each part of the EKG in the same order every time. So after you do that, you're going to compare your analysis to the rules for each dysrhythmia, and then you'll identify the dysrhythmia by its similarity to the rules. So right now we're going to talk about a 4-step procedure for identifying the rhythm. As we look into 12-lead EKGs, we're going to adjust that 4-step procedure into a 7-step procedure. But for now, whenever we're dealing with simple rhythm interpretation and not the interpretation of the 12-lead EKG, we're going to stick to these 4 steps. And with these 4 steps, you should pretty much be able to identify any heart rhythm that really a patient can have. So our first step, and remember we're going to try and do this the same way every time, is to analyze the rate. We'll then analyze the rhythm, whether it's regular or irregular. We'll analyze the P waves and the PR interval, and then we'll analyze the QRS complexes. And just by looking at those 4 different things, we should be able to pretty much determine any rhythm that a patient could be in. So, first thing that we want to do is identify the rate. We know that a normal heart rate is somewhere around 60 to 100 beats a minute. So we want to know, is the rhythm faster or slower than that, or is it within that range? So we're going to take the number of QRS complexes in a 6-second strip and multiply it by 10. There's also another way that we can do it. We can also, our computer readout is usually fairly accurate that we can use as well, as long as there's no artifact. But we'll talk about that here and look at another way as well. So if you look at the another way to calculate the rate, we're going to look at a QRS complex that falls on a big line, and then we can use these numbers here to kind of give us a general idea of just about where that patient's at as far as their heart rate. So if we look at the QRS complex on the left-hand side, just beneath the star, that's sitting on a big line, and then look at the next big line over, and remember, and these are just numbers that you will have to memorize. So the first big box is 300, the next big box is 150, the next one 100, and then the next one 75, and then 60, and then 50. So we see that our heart rate is falling between the 75 and the 60, kind of towards the 60 a little bit, and we're just looking for where the next beat falls. And this is useful in patients that have a regular rhythm. If they have an irregular heart rate, then it's really difficult to use this, and you just need to count the number of beats in a 6-second strip and multiply it by 10. But if they do have a regular heart rate, then we can use this method here. So this rule up here, we can kind of see the patient's heart rate is just about 64, 68, somewhere in there, and that's good enough for our purposes here. We are then going to recognize whether the rhythm is regular. We want to know if it's regular or regularly irregular or irregularly irregular. Those are basically the three different types of rhythms that we can have. If it's regular and they're having, there's equal intervals between each QRS, we can say that it's regular. If it's irregularly irregular, they could be all over the place. Their heart rate could, they could have a beat here, beat there. There's just no equal time between any two beats. That's going to be irregularly irregular. If we have a regularly irregular heartbeat, then we know that it's we have some type of pattern. Patterns are generally pretty easy to pick out. If we have 3 beats and then we drop a beat, and then we have 3 beats and we drop a beat, it's pretty easy to recognize that it's irregular, but it's regularly irregular. We have some sort of pattern that the heart rate is following. Here's our example of a regular rhythm. It's consistent. The cadence of the rhythm is constant and steady. Normal sinus rhythm or regular sinus rhythm is going to be our big regular rhythm. So if you look down in the graphic here, we see our R-to-R interval between each of these 4 complexes is constant, and it doesn't ever change. It's regular. It's the same distance between every set of beats. All right, so then we can have our regularly irregular rhythms. The regular cadence of the rhythm is interrupted by something. The pattern is recurring. And so if we look at our first example here, considering these are all QRS complexes on an EKG, we have 4 beats, and then we have a drop beat. We have 4 beats, and then we have a drop beat, and that continues. So that's regularly irregular. And the second example is the same thing. We have 2 beats, drop a beat, 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 etc. And then the third one as well. Just every other beat is dropped for whatever reason. And we'll get into these and look at pictures of them as we move forward. So, and then example 4, we have 5 beats, and we drop a beat, and then 4 beats, and we drop a beat, and then we have 5 beats, and then drop a beat, and 4 beats, and drop a beat, etc. So hopefully that makes sense, and I think it'll be easier once we start looking at some actual rhythm strips here. Now we're going to discuss our irregular rhythms. This is a completely chaotic rhythm. It doesn't have any cadence. It's caused by multiple pacemaker sites throughout the heart firing on the throughout the heart. Sorry about that. We have a completely different cadence. There's really no organization to it. It's just kind of here, there, and everywhere. Also can be caused by re-entry circuits. We'll get into that later on. As far as the QRS complexes and the P waves, we want to know, are the P waves and the QRS complexes associated with one another? Do we have any does every QRS complex have a P wave that's next to it? And we want to know, are the QRS complexes narrow or wider than they're supposed to be? Are the QRS complexes grouped together or not grouped? And are there any dropped beats? And we'll talk about each of the rhythms and how they differ from this concept here. So first we're going to talk about regular sinus rhythm, and we're really just going to have to go through and look at the rules for each rhythm that we have, and then look at the differing rules and how we're going to establish what the heart rhythm is. So normal sinus or regular sinus rhythm, we're going to be looking for a rate. Remember, we're going to do our 4-step method here. The rate is 60 to 100. The rhythm is regular. There's no drop beats. We have P waves that are normal and upright, and there's one before each QRS complex. The interval between our PR interval is going to be 0.12 to 0.2 seconds. QRS complex should be normal duration of less than 0.12 seconds. Here's an example of normal sinus rhythm. We have we have our P waves in front of every QRS. Our rate is 60 to 100. Look at our second beat from the left, our second beat, and using our method that we talked about with the big boxes, we can ascertain that our rate is between 60 and 100. So we go our first big box over from the second beat is going to be 300, 150, 100, 75, and then 60. So it's between 75 and 60, so probably 64. So we know that it's between 60 and 100 beats a minute. We can look and see, looking at it from here, it looks like it's pretty regular. Without a set of EKG calipers and actually putting it on there, it may be a little irregular, but more than likely it's pretty regular. Our P waves are present. We have a P wave before every QRS. Our PR interval is less than 0.2 seconds. Look at the second beat again and see the wave starts right on a big line, and then the PR interval ends before the next big line, so we know that it's normal duration. We don't have any grouping or drop beats. Our QRS width is less than 0.12. So that's pretty much it. We know that we have a regular sinus rhythm here. So now that we talked about the one normal rhythm that we have, we're going to talk about our dysrhythmias, or variants from normal sinus rhythm. First, we're going to talk about causes of dysrhythmias. There's a ton of causes of dysrhythmias, and to be honest, whenever somebody has a given dysrhythmia, usually the cause is idiopathic. They never really find the exact cause of it, but there are some things that can lead us down the path of what caused it. Myocardial ischemia or infarctions are a big one. Any imbalance in the autonomic nervous system, autoimmune diseases that affect the autonomic nervous system, distension in the chambers of the heart, blood gas abnormalities, electrolyte imbalances, all the ones on the right as well. Any trauma to the myocardium, or drugs, electrocution, hypothermia, CNS damage, and then, like I said, idiopathic events and normal occurrences are pretty common as well. All right, so our first, not necessarily dysrhythmia, but something we need to mention is premature complex. Anytime we have a complex, a QRS complex, or even just a P wave that occurs before it's supposed to, we call this a QRS complex, or a premature complex. These can arise from the sinus node, from the atrial tissue, from the AV node, and the ventricles. So we can have premature complexes that come from pretty much anywhere in the conduction system. So we're going to look at some examples. These are recurrent premature complexes. We can have isolated complexes. You just see one here and there, and they're not regularly premature. But in these examples here, we do have a example of premature complexes that are consistently there. So in our top example, this would be example of bigeminal premature complexes. After every regular beat, we have a premature beat. The second one down would be trigeminal. Every third beat is premature, and then quadrigeminal is the fourth one, or the third one down, where every fourth beat is premature. Okay. Now we're going to talk about escape complexes. What these are is a complex that occurs from an absence of the pacemaker providing the normal stimulus that it's supposed to. So if the sinus node fails to fire for a given length of time, we are going to see an escape complex from somewhere to reestablish the heart rhythm. So just because the sinus node fails to fire doesn't mean that the heart just doesn't beat. Eventually, after several seconds from the pacemaker from somewhere, be it the sinus node or elsewhere in the conduction system, is going to go ahead and provide a beat that is going to reestablish the pacemaker responsibility. So you can have a escape complex from pretty much anywhere in the conduction system. All right, so we're going to talk about some dysrhythmias. And the dysrhythmias are classified by their origin, the magnitude, and the severity. So we'll get into some deeper classification here and kind of describe what we're looking for whenever we do see a dysrhythmia and how we're going to identify it. Dysrhythmias classified by the site of origin. We can have dysrhythmias originating in the SA node, originating in the atria, the AV junction. These are usually AV blocks. We can have dysrhythmias that are sustained in or originating in the AV junction. Dysrhythmias originating in the ventricles, and we can have results of disorders of conduction. So we'll start by talking about dysrhythmias originating in the SA node. Sinus rhythms, they all originate in the SA node. The major difference between regular sinus rhythm and any type of dysrhythmia is going to be the rate and the regularity of the rhythm. So two things common to all of them. All the P waves are identical, and all the PR intervals are the same. So in any sinus dysrhythmia, we need to make sure that we have P waves that are identical, and the PR wave isn't variable. So we have our normal sinus rhythm. You guys remember the classification of normal sinus rhythm. Our heartbeat of 60 to 100 beats a minute. All the P waves are identical. The PR intervals are identical, and we have a regular heart rate. When we have sinus bradycardia, we're going to have all that same thing, except the heart rate is going to be slower than 60 beats a minute. Pretty simple. Everything's the same except the heart rate. If the heart rate drops below 60 beats a minute, it's considered sinus bradycardia. Likewise, in a heart rate that is faster than 100 beats a minute, we're going to call that as tachycardia. We also have what's called sinus arrhythmia. These the rate can be variable in sinus arrhythmia. It can be normal, or it can be bradycardic and tachycardic. We'll also have P waves that are identical. We'll have all the PR intervals identical, but we're going to have an irregular heart rate. So we'll talk about these in greater detail. Sinus bradycardia, as we already discussed, it still originates in the SA node. The rate is less than 60 beats a minute. The P waves and PR intervals are identical, and the TP segments are long because of the slowed heart rate. Sinus bradycardia is considered a cardiac emergency when there's hemodynamic compromise. So what this means is that there are people that are walking around and they are in sinus bradycardia, and that's normal for them. It's nothing to worry about. You see it a lot in people that work out a lot, people that are sleeping or have just woken up from sleep. In marathon runners, you can see heart rates down in the 40s because they have such great cardiovascular endurance. That their heart rate is just at rest is normally, in the 40s, and that's normal for them. The problem arises when it's not normal for them and they have a heart rate in the 40s and they have significant compromise, they're in hemodynamic shock. because they're unable to maintain their blood pressure, maintain adequate perfusion due to the low heart rate. This is when it becomes a problem. Recognition of sinus bradycardia. Remember, it's the same as sinus rhythm or regular sinus rhythm, other than the heart rate being less than 60 beats a minute. Here we have our example of sinus bradycardia. Measuring the heart rate, we can look at the third beat here, which is sitting on a big line, and we measure over. So we have 300 at the first big box, 150, 175, 60 beats a minute. This is borderline sinus bradycardia. The differential diagnosis for sinus bradycardia. We can have increased vagus nerve stimulation from vomiting or carotid sinus massage. Remember, the vagus nerve is what stimulates the parasympathetic system. So anytime this is stimulated greater than it needs to be, it's going to cause a bradycardic rhythm. It can also be associated with myocardial infarction, increased intracranial pressure, hypoxia, hypothermia, and then several more as well. Sick sinus syndrome over there on number 8 is one that we'll talk about later on. Tachycardia originates in the SA node. Everything's the same. The rate is greater than 100 beats a minute, though. Our P waves and PR intervals should be identical. Rapid rates may cause some narrowing of that PR interval. The TP segments are going to be short due to the faster heart rate. Their rates are typically less than 160 beats a minute, but they can jump as high as 220 beats a minute. Somebody that's very worked up, or somebody that's in hemodynamically compromised for another reason. So, briefly talk about electrical alternans. Pretty common finding tachycardia. What this means is that your QRS complexes vary in height. So if you look at our first example there, we have a pattern of a shorter QRS and a taller QRS and so on. It kind of goes back and forth. This is a example of electrical alternans. In the second example, you see there's a pattern, but they just get taller, taller, and taller, and then shorter, shorter, and shorter. And this will continue throughout the rhythm strip. This is a pretty common finding that you'll see in any tachycardia. Also, remember to keep in mind that the TP wave may be the cause of ST depression and tachycardias, and this will make a little more sense as we start talking about depression of the ST segment and why it's important to us. But normally the atrial repolarization wave is buried, and you see it. But with a faster heart rate, it may be superimposed on the ST segment because it's a little behind, and it can cause the ST segment to be depressed. So back to sinus tachycardia here. Remember here that everything's going to be consistent with regular sinus rhythm. The only difference we're going to have is that our rate is greater than 100. So here's an example of our sinus tachycardia. We have our regular rhythm. We have P waves present in front of every QRS. Our PR interval is normal. Our QRS width is normal. We don't have any grouping or drop beats, but we do. Our only difference is that we have a rate greater than 100. Differential diagnosis for sinus tachycardia. Exercise is a pretty common one. Anytime you exercise, your heart rate's going to get increased. Anxiety, stress, fever, hypoxia, all of these here can be causes of tachycardia. Our sinus arrhythmia originates in the sinus node still. The P waves and PR intervals are still consistent, but the P to P interval varies greater than 0.16 seconds or 4 small boxes on the strip. So we'll look at some examples here. Greater. I don't really like this picture; it doesn't really represent it. But what we're saying here is that these blue lines are our P waves on a rhythm strip, and the P wave is variable. It measures differently throughout the rhythm strip. And this is just a way that you can calculate the whether somebody's in sinus arrhythmia or not. There's 2 types of sinus arrhythmia. One of them is respiratory sinus arrhythmia, and the other is non-respiratory or non-phasic sinus arrhythmia. In respiratory sinus arrhythmia, we have to consider what's going on as we're breathing. As we breathe in, we're going to create a decrease in the intrathoracic pressure. There's a negative pressure in the chest cavity that's going to force blood into the heart and the lungs. As we breathe out, it increases the pressure in the thoracic cavity, and then what this is going to do is force blood out into the system. So whenever we breathe in, we're pulling blood into the thoracic cavity, and when we breathe out, we're pushing blood out. So as we do this, we see a change in the heart rate associated with this. So looking at our graphic representation, we have expiration. During the inspiration phase, we have an increase in the heart rate, and during the expiration phase, we have a decrease in the heart rate due to the demands of the body. It's usually pretty subtle change. Most people have a moderate amount of sinus arrhythmia associated with the respiratory rate. As it's something that's you don't always pick it up, but whenever you do see it, it's just something to note. It's not pathological if it's respiratory sinus arrhythmia. It is a normal variant. Non-respiratory sinus arrhythmia is not a normal variant. It's there's a pathology. You see it in cardiac disease and elderly. And the difference is that you don't really see a pattern, but the P waves and PR intervals are sinus. So you have a sinus arrhythmia and there's no pattern to it. It's usually going to be pathological. So here we have our sinus arrhythmia recognition. We have our heart rate at 60 to 100 beats a minute, but it can be slower or faster than that. Our regularity is what the difference is going to be. It's usually regularly irregular, but it can be irregularly irregular as well. The P-wave morphology is sinus in origin. It's going to be the same and upright in lead 2. The P to QRS ratio is 1. There's going to be 1 P wave for every QRS complex. The PR interval should be consistent. The QRS width should be normal, and there's no grouping or drop beats. So here we have our example of sinus arrhythmia, and later on we'll have a better example of this as we look at some practice strips a little bit longer and helps you see the pattern. We're going to talk about sinus block. What happens in a sinus block is you have a failure of the sinus node to capture. It doesn't depolarize the atrial myocardium. The block can last 1 or more cycles. The pause is an exact multiple of the P to P interval. So whenever our heart rate does pick back up, it should march out to where we pick up where we left off, so to say. So unless we have an escape complex, but normally with sinus block, you're going to see it'll march out to where you see here in the bottom how our P to P intervals, even though we're missing a beat in the middle there, they still match up, and they're, they would be regular had that beat been there. We're missing one beat, and then it picks up where it leaves off, but it can be multiple beats as well. Our rate in sinus block is going to be variable. It's irregular because we are missing beats. Our P waves are going to be present except whenever we have an area of drop beats. There should still be a QRS for every P wave. You have normal PR interval and QRS width. There's no grouping, but you do have drop beats. I want to talk about sinus pause. Sinus pause is a delay of the sinus node to capture or to polarize the atrial myocardium. The delay causes a lengthening of the P to P interval. The pause is not an exact multiple of the P to P interval, and it's usually longer than what you see in a sinus block. So in our picture here, you see our sinus pause. It does not march out as in sinus block. So this is the differentiation between sinus block and sinus pause, is that it's not an exact multiple of the P to P interval. Sinus arrest is a very long delay of the sinus node to capture. The delay causes prolonged lengthening of the P to P interval, and it's also not an exact multiple of the P to P interval. Sinus arrest is longer than a sinus pause. The only difference is the length of it. There is varying descriptions of sinus pause versus sinus arrest. Usually they say, if there's a rest greater than 3 to 4 seconds, then it's going to be considered sinus arrest. If the pause is less than that, it's going to be either sinus block or sinus pause, depending on if the P waves march out in the intervals. So with sinus pause and sinus arrest, the rate is going to be variable depending on how many pauses you have. You have an irregular heart rate because those drop beats. The P waves are still present. Your P waves and QRSs, you should have the same number of them. They should be attached to each other. PR interval and QRS width is still normal. There's no grouping, but we still have drop beats. So we see here our P to P interval does not march out as it does in sinus block. We have this pause or arrest, and it just kind of kicks back in whenever it wants to. Like I said, there is no real clear-cut difference between sinus pause and a sinus arrest. The rule of thumb here that I have in here is 3 P to P intervals. Longer than that is going to be considered sinus arrest. Differential diagnosis here. Sick sinus syndrome is a diagnosis. It's actually its own dysrhythmia. Whenever you start seeing multiple sinus pauses, it's usually something to consider. Sick sinus syndrome. The diagnosis of sick sinus syndrome is I believe there's a certain number of pauses that have to occur per minute for that to be diagnosed. Coronary artery disease, hypersensitivity to carotid sinus syndrome, digoxin is a common cause of it, electrolyte disorders, and it can be idiopathic as well. Premature atrial contractions. These are impulses, and we've already kind of talked about these before. Complex that occurs earlier than it is supposed to, and it originates somewhere other than the SA node, but still in the interatrial pathways. It's due to increased automaticity in an atrial focus, normally clinically insignificant unless you start seeing a bunch of them. So here we have the formation of a PAC. We have our first 2 sinus beats occurring. And then before the next beat, we have a premature contraction. You notice that the P wave on that third complex, the one that's highlighted in red, is different than the other ones because it occurred at a different location. The stimulus began at a different location than the sinus node. So our star highlights with the irritable focus that started the PAC, and that's pretty much all it is. It's a single beat that occurs in the atria that happens sooner than expected. QRS complexes with PAC should still be normal. Once it hits the bundle, once that stimulus hits the bundle of His, it's pretty, it's going to occur at everything from there is going to be normal. So our ST segment, QRS complexes, it should all be normal. P wave morphology, like I already said, is going to be different. You may have a shorter PR interval due to the location of the foci because it's a shorter route to depolarize everything. The P wave axis is the direction of the atrial axis creating the P wave morphology. So normally we have our P wave that starts in the sinus node, and then it moves down and to the right, down towards lead 2, where our positive electrode is the left leg. So it's going to deflect positively. If it depolarizes lower and has to retrograde depolarize the atria, it's going to go backwards. So it shows up as a negative deflection on our EKG. So what happens is we have you can either have a non-compensatory pause or a compensatory pause when you have a PAC. Whenever you have a non-compensatory pause, the pause encompassing the PAC will be different than 2 times the P to P interval. So what I'm saying here is that we have our PAC occur, and then basically what happens is the SA node is reset when that PAC happens. So our P waves are not going to march out as they would in a compensatory pause. And we'll look at an example of that here in just a second. Since the SA node is reset with the PAC, our normal heart rate starts again once after the PAC. So they should start marching out after the PAC occurs. In a compensatory pause, the pause is going to be the exactly 2 times the P to P or R to R interval. This happens because when the PAC happens, the SA node is reset. So basically, we lose 1 beat because of the PAC, but the timetable isn't reset. So everything, the P waves will continue to march out. We're just missing the one in the middle. So here you see the P wave on the left side of the bracket. We're missing the one in the middle, but the one after that is in the correct spot. Since the P wave falls on an exact multiple of the P to P interval, it's a compensatory pause. The rhythm isn't reset here, so the P to P interval stays the same. Occasionally you can have a premature P wave that falls on a T wave. It may give the impression that the previous T wave is double humped, may look biphasic. The fusion of the 2 impulses is called a buried T wave. A picture of that here. You see on the first picture above, you have a small hump where your T wave happens, and then you see your P wave that's buried right at the end of it. In the second example, you have one that kind of falls right on the middle of the P wave, and it just makes it look like a large humped T wave. All right, we're going to talk about blocked P waves here. Basically what happens, you have atrial depolarization, but the stimulus is blocked from reaching the ventricle because the ventricles, if you remember, we talked about they're refractory period of the ventricles. So if the ventricles are still refractory to an impulse, basically you can have a P wave that happens, but the ventricles aren't able to depolarize because they're in their refractory phase. So here's an example of a blocked P wave. You have a P wave sticking out right by the T wave, but since the ventricles are refractory, it doesn't go anywhere. You just have a P wave and then a pause, and then your rhythm continues. So identifying PAC arrhythmias, it's just a single complex. It can be regular. The P wave is going to be different morphology during the PAC. It's going to be can be upright in lead 2, but not always. P to QRS ratio should still be the same. The PR interval can be different during the PAC. QRS width and should be the same. So here we have in our example, this third complex is our PAC. Looking at the brackets above, you see that the P wave falls sooner than expected. And in this particular example, we have a compensatory pause. Differential diagnosis of PACs. Most commonly, they're going to be idiopathic and benign. I don't really know the cause of them. They just do occur. Everybody has PACs time and time again. Pretty common abnormality to have. It can be caused by anxiety, nicotine, enlargement of the atria, heart disease, and electrolyte disorders. We're going to talk about our next dysrhythmia that originates in the atria. Wandering atrial pacemaker. This is an irregular rhythm. It's caused by different pacemakers occurring in the atria. For whatever reason, the SA node is not doing its job, and we have different P-wave morphologies caused by different atrial foci that are taking over pacemaker responsibilities. This is going to cause us to have differing PR intervals because of the different locations of the ectopic foci that are causing our P waves. So with wandering atrial pacemaker, we're going to have differing P-wave morphologies and PR intervals. For a diagnosis of wandering atrial pacemaker, there has to be at least 3 different pacemaker sites. So when we look at our EKG strip, we need to have at least 3 different morphologies of P-wave to determine that it's a wandering atrial pacemaker. Here's a little example. So if you look at pacemaker 1, close to the sinus node, but it's not there. We have a P wave that's arising from this particular focus. And then we have pacemaker 2, and this is causing a different P wave morphology due to the location of it. It's kind of sitting in a different area. And then pacemaker 3 is way off in the left atria, causing an even more different morphology of P waves due to its location as well. So here in our example, we have pacemaker. Pacemaker 1 is our regular pacemaker, so to speak. We have 3 different pacemaker sites. They're all providing stimulus, so they are kind of occurring at different times as they all try and work their way down. Look at some examples of what this is actually going to look like here. You do see that we have a pretty irregular rhythm here with all our different morphologies of P waves. So recognizing a wandering atrial pacemaker, our rate needs to be less than 100 beats a minute. It's going to be irregular. There will be P waves for every QRS. The P waves are present, but the morphology is variable. Some of the P waves are going to be upright in lead 2, but not all of them. The PR interval is variable. The QRS width should be normal, and there should not be grouping. You can have an occasional drop beat from this, depending on where the focus hits at on the previous T wave. So here we have our example of a wandering atrial pacemaker. You look, and our first 3 beats all have different P wave morphology. Our P wave is kind of humped. Our second one's a little wider and more flat, and then our third one is extremely close to the QRS complex. Note that we remember that our PR interval can vary due to the differing locations of the pacemaker cells. Our rate here is 100 beats a minute. It's irregularly irregular. Kind of hard to tell from the picture, but if you did have calipers, you'd be able to tell that it was irregular. At least 3 different morphologies of P waves. We do have a QRS for every P wave that we have. The PR interval is variable. There's no grouping or drop beats, and the QRS width is normal. Differential diagnosis of a wandering atrial pacemaker. COPD, respiratory failure, atrial enlargement, electrolyte abnormalities, and then drugs. So, kind of the sister to wandering atrial pacemaker is going to be our supraventricular tachycardia, or multifocal atrial tachycardia. What this is a rapid supraventricular tachycardia. Think about that terminology there. Supra, it means superior, and ventricular, obviously referring to the ventricles. So we know that this rhythm is arising from above the ventricles. It's not a ventricular rhythm. It has at least 3 different atrial pacemakers. The rate's anywhere from 100 to 150. It's a tachycardia, so it's got to be at least 100. Irregularly irregular. 3 different P wave morphologies and 3 different PRs. And then we're going to have fusion and buried P waves, and aberrancy is also common, meaning you can have the appearance of a elongated QRS complex even though there's no pathology causing it. Here's an example of a multifocal atrial tachycardia. You'll notice that it looks remarkably similar to a wandering atrial pacemaker. The biggest difference is going to be the rate. So we have our 3 different atrial foci that are causing our pacemaker beats. Our first one here is the pink. That's kind of a biphasic P wave. The green is our undulated negatively deflected P wave, and then our third one, our purple, is kind of that humped up peaked P wave there. Notice that in this 5th complex we do have the P wave buried in the previous T wave, kind of giving it the appearance of a humped T wave there. This is most commonly seen in patients with chronic lung disease. It can be seen in the elderly. The best treatment strategy to treat the underlying cause. Recognizing it here, we need to look at the rate. It's going to be 100 to 150 beats a minute. Our biggest variable, like I said, is going to be the rate whenever we're trying to differentiate between a wandering atrial pacemaker and a multifocal atrial tachycardia. All right, here's our example. We have 3 different P wave morphologies here. We have an irregularly irregular rhythm. The rate's greater than 100 beats a minute. The P to QRS ratio is still 1 to 1. The PR interval is variable. We still have normal QRSs here, and there's no grouping or drop beats. Again, differential diagnosis is going to be COPD, respiratory failure, electrolyte abnormalities, and nicotine, alcohol, caffeine. The next rhythm we're going to talk about is atrial flutter. Atrial flutter is a rapid rhythm with a rapid atrial rate, up to 400 beats a minute on that atrial rate. The ventricular rate can be variable between 140 and 160 beats a minute. Typically, it's a very regular rhythm. And this is usually a pretty distinguishing rhythm. It's pretty easy to pick out because we don't really see P waves. We see what we call flutter waves or F waves. There's no associated isoelectric line between the F waves. They're continuous up and down, up and down. The biggest thing to remember with a atrial flutter is the sawtooth pattern. This is the most distinguishing characteristic that's going to help us pick out what we're looking at. F waves are made as a reentrant mechanism. Impulses originate at the top of the mechanism and they move through an area of slower conduction. This slowdown allows the top to become receptive to the returning impulse. So basically you have an impulse that is continuously looping around in the ectopic foci that's causing your flutter waves. It's the same impulse being received over and over again by the previous stimulus, making it an extremely fast rhythm. The conduction ratio versus the block. What we're referring to is the actual conduction rate through the AV node. This is how many impulses are actually transmitted down to the ventricles. This can be a protective mechanism. If we had every atrial stimulus with a rate of 300 going down to the ventricles, we're not going to be pumping very effectively. So basically the AV node is slowing down, attempting to block some of those impulses from getting through. So what we're saying is that a 3-to-2 conduction rate means there's 3 complexes, but only 2 ventricular complexes are going to be triggered. Block refers to a pathological interruption of AV conduction. 3-to-2 block means that for every 3 atrial impulses created, 2 are going to be blocked. So the most common atrial rate in atrial flutter is 300 beats a minute. And then the most common ratio of conduction ratio is going to be 2-to-1. So for every 2 atrial complexes, only 1 is actually reaching the ventricles, meaning that our ventricular rate is going to be 150 beats a minute. So here we have on the top of the example, this is our atrial rate up here of 300 beats a minute. Atrial flutter with 4-to-1 conduction, meaning that for every 4 impulses from the atria, 1's getting through. Atrial flutter at 2-to-1 conduction, for every 4 impulses or 2 impulses, 1 is getting through, so half of them. Ventricular complexes are typically narrow, but they can be wide in cases of aberrancy, pre-existing bundle branch blocks, or electrolyte abnormalities. You can also have various variable conduction with atrial flutter. It's caused by constant fluctuations in the conduction ratio through the AV node, typically due to some type of pathology, and it can cause an extremely irregular rhythm. So recognizing atrial flutter, remember most commonly seen atrial rate is going to be 300 beats a minute. And then with a 150 beats per minute ventricular rate. The regularity may vary, but it's usually fairly consistent. We don't see any P waves. We see, remember, our sawtooth pattern or flutter waves. It's usually 2 or 4-to-1 conduction. There is drop beats. And there can be grouping of the QRS complexes if the AV block is advanced. Here's an example of typical atrial flutter with 2-to-1 conduction here. So we look at our flutter waves and you look at the peaks of them and you find one. You notice that it is fairly consistent and it is right at about 300 beats a minute here, and it's pretty regular. Our atrial rate is about 300, and it's 2-to-1 conduction, and our ventricular rate is sitting right at about 150. Differential diagnosis of atrial flutter. MI, drugs, digoxin is a very common one. Pulmonary embolism, pericarditis, and pneumonias. Next, we're going to talk about atrial fibrillation. Atrial fibrillation is another irregular rhythm. In AFib, you're going to see absence of observable P waves. What you do have are flutter waves. Fibrillation is due to multiple pacemakers or multiple reentry circuits in the atria. The fib waves are anywhere going from 400 to 700 beats a minute. The ventricular response is variable. So here we have an example of atrial fibrillation. Notice the ventricular rate is irregular. Here we're pointing to some of the fibrillation waves there. You can see them. You don't always really even see the fib waves in real life. Talking here, you don't always see those, especially in patients that have had a history of AFib for years and years and years. What happens is those after years of those extremely high rates of fibrillation, you'll see those atria kind of lose their kick. They lose that ability to create that conduction. So you really, some of these patients, you may not even see the flutter waves. You may just see an irregular QRS complex with no discernible P waves. There's nothing really between. So there is different classifications of atrial fibrillation. You can have paroxysmal AFib. It's an acute episode of it. They're usually short-lived, but they do recur over time. You can have persistent AFib, which is a chronic form. It can be converted back into a sinus rhythm or some other rhythm. And then you can also have permanent AFib, which is chronic and it's stable, and it can't be converted, or it can be converted, but it always comes back to AFib. Kind of what I was talking about earlier. There's a spectrum of fine AFib to coarse AFib. You look at the top, and you really don't even see any flutter waves. And then down at the bottom, you see the coarse AFib, where the flutter waves are very discernible and at a rapid, irregular rate. Okay, for a moment, we're going to talk about Ashman's phenomenon. Basically, what we're looking at here, you guys remember we talked about aberrant conduction, a little maybe better explanation of that. Aberrant conduction is basically the result of the incomplete return to normal of the ventricles or the Purkinje fibers. You have a impulse that is conducted while the ventricles are still in their relative refractory period, and you get what we'll call a bundle branch block morphology, sometimes referred to as incomplete bundle branch block morphology, and can be the case with any supraventricular rhythm. You can have these beats, or you can have a rhythm that has an aberrant look to it. It's seen often in SVT, supraventricular tachycardias, due to the speed with which each impulse is coming down. You get to a point where the ventricles aren't able to repolarize before they receive the next impulse, and so it takes longer for that stimulus to reach to stimulate both ventricles, so you get a wide appearance of the QRS, wider than the 0.12 seconds, which is our maximum for a normal EKG, for a normal QRS complex. So That's a rundown of what aberrancy means. It's something that will come more into play whenever we start talking about tachycardias, ventricular tachycardias, and differentiating them between SVT with aberrancy. Specific to atrial fibrillation, kind of along the same line, Ashman's phenomenon is an aberrant beat, premature beat usually, following whenever you have a long R to R phase, and then you have a premature beat with a short R to R phase. With a short interval, you have the ventricles not fully repolarized. They're still refractory. Commonly, the right bonal branch is more refractory, and so this impulse takes longer to travel down the right bonal branch. So you have a wider complex. It's seen here. This beat, the one with the red arrow pointing to it, you'll notice that it's a fair bit wider than the previous complexes, and that's the reason for it. Those ventricles aren't fully repolarized, and they receive that next stimulus from above, and it just takes longer for it to travel down the right bonal branch block. And this is known, or the right bonal branch, excuse me, and this is known as Ashman's phenomenon. It is diagnostic criteria for atrial fibrillation. Digoxin is a very common medication. You'll hear it referred to as digoxin, digitalis, lanoxin. These are all the same medication. What you'll find is that a lot of these patients that are the atrial fib patients are taking digoxin, and what digoxin does is it slows and strengthens. So what it wants to do is slow the number of impulses that are reaching down into the ventricles, and then it's going to strengthen ventricular contraction. I've mentioned before that digoxin is a positive inotropic agent, and what this simply means that it's strengthening the contraction of the ventricles. The problem that you have with atrial fib is that since your atria are not pumping appropriately, you lose what we call your atrial kick. Your atrial kick is that extra amount of blood that whenever the atria pump into the ventricles, it fills the ventricles to the appropriate level, so it's able to adequately pump. So in an atrial fib patient with an atrial rate of 400 to 700 beats a minute, obviously we're not pumping effectively out into the ventricles. So digoxin is used to strengthen that ventricular contraction since the atria aren't there to give that extra amount of blood. There is a indication on the EKG that you're sometimes able to see whenever digoxin is in its therapeutic levels, known as the digoxin effect. Basically, what this looks like, mostly in the lateral precordial leads, you will see what looks like an ice cream scoop out of the ST segment. It can be mistaken sometimes for ischemia due to the ST depression, which we'll get into later. But just know that that is a sign that you can sometimes see on the 12-lead ECG. AFib recognition. Just remember that we're not gonna have P waves. We're gonna have these fibrillation waves. You're not gonna be able to really calculate the rate. It is usually pretty recognizable. It is an irregular rhythm with a variable ventricular rate. There's no P waves, there's no P to QRS ratio, no PR interval. The QRS width should be normal, except when we were discussing Ashman's phenomenon, there's no grouping or dot beats. So here, whenever we see any irregular rhythm, one of our first thoughts is to be considering atrial fib. We don't see any P waves here. The rest is variable. Generally, what we're going to say is with atrial fib, we give it terminology as controlled or uncontrolled. Controlled AFib is when our ventricular heart rate is 60 to 100 beats a minute. Anything below 60 or above 100 is considered to be uncontrolled AFib. Differential diagnosis for atrial fib, atrial enlargement on the left side, generally age, previous coronary artery disease, and a lot of times it is idiopathic. At this point, we're going to do some practice, good just based on the rhythms that we've been, the arrhythmias that we've been talking about. So make sure you have your little cheat sheet handy as we go through these, and just kind of follow along and try and figure out what we're looking at as we go through these. Okay, so the first rhythm here that we have, beginning with, remember that we're going to be using our 4 steps of EKG interpretation. So our first step here is that we want to determine the rate. Using our method, we can either take a 6-second strip and multiply it by 100, or we can count with our boxes. Looking at this third complex here, it looks like it's fairly close to a big box, so we're going to go 300, 150, 175, 60, so right about 60 beats a minute. Next, we will determine if the rhythm's regular or irregular. To me, from my computer screen, it looks like it's pretty regular. So then we want to look at the P-wave morphologies. We have, looks like one P-wave. It doesn't look like it varies any. We have a P-wave in front of every QRS. Our QRS appears to be within normal limits. It's less than 0.12. So from that, we can determine that everything seems to be checking. It looks like this is just a case of normal sinus rhythm or regular sinus rhythm. Okay, again, we're going to start determining our rate. Okay, if you figure that up, it looks to me like the rate's about 75 beats a minute. We need to determine if it's regular or irregular. It looks to me to be fairly regular. We have a P wave in front of every QRS. Our QRS morphology are similar. Our P waves are similar. So this is another regular sinus rhythm. Again, determine our rate. Looks to be just mildly bradycardic, maybe around 56 beats a minute. Our rhythm appears to be regular. We have a P wave in front of every QRS. We have QRS complexes that are similar and narrow. This appears to be a sinus bradycardia. Again, we're going to start at the beginning. This one appears to be even slower than the last. It looks like it's around 50 beats a minute. It appears to be regular. We have P waves in front of each QRS. The P waves are similar. The QRS complexes appear to be similar. This is another sinus bradycardia. Our rate is 60. Our rhythm is regular. It looks like we have a P wave in front of every QRS. The P waves appear to be similar. Our PR interval is within normal limits. Well, the only thing that we really, it almost looks like we can't quite see the P wave on this beat on the very far left, but we can assume that it's probably there since the rest of them are. Might need a longer strip to tell. We have P waves in front of each QRS. Our QRSs are of normal duration. There doesn't really appear to be anything else sticking out, so we have another sinus bradycardia. Our rate looks like it's right at borderline, right at 60. So it could be a sinus rhythm or sinus bradycardia. So we need to determine our rate. Looks like about 110 beats a minute. It looks to be regular. It appears we have a P wave in front of each QRS of similar morphology. Our PR interval is constant. Our QRS complexes are narrow. That shows this to be a sinus tachycardia. Our rate, about 145 beats a minute. It appears to be regular. It looks like, if you guys remember, we were talking about the electrical alternons, the pattern of shorter and taller QRS complexes. It looks like we have that here. If you look from the left, the complexes get taller until about the fourth or fifth beat, and they get shorter, taller again, and shorter again. We have a P wave in front of each QRS complex. Our P waves are similar in morphology. Our PR interval is constant. We have a QRS for every P wave. The QRS complexes are narrow. This is sinus tachycardia. Here we have a rate of about 70. We have a P wave in front of each QRS, but we do have this irregularity here. So what we need to determine is if that is, it's pretty easy to see this pause right here after the third beat. So what we need to look at here is if our our R to R interval marches out, and it appears that it does. We have an R to R interval that marches out, so more than likely this is a sinus block. We miss one beat, and then the sinus rhythm resumes following the block. It didn't reset the timetable. It wasn't a pause, and it wasn't an arrest. It wasn't long enough to be an arrest, and since the timetable didn't reset, it's not a pause. So this shows us that it's a sinus block. What is our rate? It would appear that our rate is about 50 beats a minute. And I'll tell you what I'm doing here. If you, hopefully we'll have you guys some paper handouts by the time you're listening to this. What I'm doing is holding a piece of paper up to the screen with two lines on it from the R to R interval, between the R to R intervals, and then I can hold it up to each complex to show if there's a premature beat. Because it's kind of hard to tell if our beat's premature without measuring it out. And if you measure it out, you'll notice that the third beat does occur prematurely. You'll just notice that there's an ever so slightly different P wave morphology in that third complex. So other than that, it looks to be fairly regular. So we know that we have a P wave in front of each QRS. Our QRS is our normal duration. So we know we have a sinus bradycardia with a PAC. The third complex is a premature atrial contraction. Now we want to know if this pause before the next beat is compensatory or non-compensatory. So we can tell that, give me 1 second here. The timetable was reset because the P interval changes between the second beat and the fourth beat. So, and hopefully this will make a little more sense when we're able to meet in person and kind of go over some of this stuff. But we are able to tell that we compensatory pause following the third beat. So the total interpretation of this rhythm would be a sinus bradycardia with a premature atrial contraction and a compensatory pause. Okay, so looking at this, we need to figure out our rate, and we can immediately tell that it's irregular. So we can't really necessarily use our method of counting out the boxes, the 300, 150 method, due to the fact that it's so irregular. So we can just count those complexes up, and it looks like there are 8 of them. So we're going to just say that the rate is 80. We know it's irregular. Now we want to know if it's irregularly irregular or it's regularly irregular. It appears to me that it's irregularly irregular. There doesn't appear to be any patterns occurring here. Now our next step is to look at our P waves. Our P wave morphology appears to change. We have our first beat has one morphology, our second beat another morphology, and it's kind of hard to tell on our third beat because the P wave is buried in the previous T wave. But then we look down at our sixth beat and we see a different morphology. So we have 3 different P wave morphologies. We do have a QRS attached to every P wave. We may even have 4 P wave morphologies if you look at that very last beat. So this tells us, when we're using our cheat sheet, we have a irregularly irregular rhythm with a rate of 80. We have 4 different P wave morphologies with a QRS attached to each P wave. So we're able to say for pretty certainly that this is a wandering atrial pacemaker. Okay, our rate, again, we're not able to use our counting method, so we'll just our box method, so we'll just use the counting them up. We're assuming that all of these strips are 6 seconds. So we'll see that there's 7 beats. We'll multiply that by 10 and know that there's about 70 beats a minute. Our rhythm appears to be irregularly irregular. Again, looking at our P wave morphologies, we see 1, 2, 3 different morphologies of P waves. It's P wave with every QRS. And so we have ourselves another wandering atrial pacemaker. All right. The heart rate appears to be 110 beats a minute. It's irregularly irregular. We have multiple different morphologies of P waves. We have a P wave with every QRS. The QRS complexes appear to be similar in morphology. They're narrow. We have a tachycardic rhythm with multiple morphologies of P waves. So we know this is a multifocal atrial tachycardia. Okay. So our rate, and what we're talking about here is our ventricular rate. So we're looking at our QRS complexes. Looks like it's about 100 beats a minute. We have no discernible P waves. We do have what looks to be flutter waves, the sawtooth pattern. It's irregularly irregular. So just from the sawtooth pattern, we're able to say that this is atrial flutter with variable conduction. The ventricular rate is variable. It's quite fast up here at the beginning, and then it seems to slow down throughout the rhythm. So we can't say what the conduction rate is, but we'll just say that it's variable. Here we note that we have a rate of approximately 150. We have a regular rhythm. This is a difficult rhythm to interpret due to the fact that the waves just before each QRS appear to be P waves. These aren't P waves. Looking at them, and sometimes it even helps if you turn the strip upside down to look at it. It kind of gives you a different perspective. But we can see that these are also flutter waves. If you look at the flutter waves just before the QRS complexes, you'll notice that you only see half of them. The other flutter waves are actually buried by the QRS complex. So that tells us that and any time you see a ventricular rate of 150, your suspicion should be high for atrial flutter. But and just so that the other flutter waves are being buried by the QRS complexes. So we have a atrial rate or a flutter wave rate of about 300 with a ventricular rate of 150. So we can say that this is atrial flutter with 2-to-1 conduction. All right. We have a rate of 110. It appears to be irregularly irregular. We have no discernible P waves. The QRS complexes appear to be similar in morphology. And that's really all we need to know. We have, anytime we have an irregularly irregular rhythm and we have discernible P waves, and we don't see any flutter waves or anything like that, then we're pretty much able to say for sure that this is atrial fibrillation. This is the last practice slide, and if you guys haven't received them already, I'll make sure that you have plenty of handouts with some practice EKG strips to work on this. Again, if anybody has any questions, feel free to contact me. My phone number is 620-870-0271. This is the conclusion of this PowerPoint. Whenever we come back, we'll be talking about rhythms that arise below the atria. We'll start talking about heart blocks and some more in-depth EKG interpretation. And once again, if anybody has any questions, let me know. At this point, everybody go ahead and try your luck on the next quiz, and good luck.
2024.